So let's do the first question of the day. The patient with LAD type 1, LAD is leukocyte adhesion deficiency type 1, and an abscess of skin would be expected to have which of the following? Mutation in NADPH gene, neutropenia, hypocellular marrow, and few neutrophils in the abscess. Okay, so this question does not need much of thinking. Let me tell you, the answer is neutropenia. Okay, why it does not need much? Because this LAD question, one thing you must remember is that this is a very frequently asked question, and the second thing is that it's very straightforward. So why exactly it is straightforward? Always remember that whether it is LAD1 or LAD2, it is always neutropenia, it is not neutrophilia. Why? Because LAD is a disorder of inflammation. Okay, you know the inflammation pathway? In inflammation there are extravascular and intravascular changes. In intravascular changes, what are the steps of intravascular changes? MRAT or whatever. So M is margination, R is rolling, A is adhesion, and T is transmigration or diapedesis. It's one and the same thing. So I'm saying that intravascular changes is MRAT or MRAD, whatever you remember it as. What are the extravascular changes? Chemotaxis, opsonization, phagocytosis. Chemotaxis, opsonization, and phagocytosis. Okay. Here there is no place, so I am writing it in a better way. I am thinking of totally finishing this chapter, all the important questions for you. In inflammation, as I said, there are intravascular and extravascular changes. Intravascular is MRAT or D, whatever, and extravascular is COP. As for margination, there is no question about it in the exam. Margination is just margination. Then for the first question is rolling is mediated by what? It is mediated by selectins and Salil-Lewis X. Salil-Lewis X. So selectins are also known as CD62. CD62. So where is selectin and where is Salil-Lewis X? Selectins are present on endothelium. Salil-Lewis X is present on WBC. And this defect, this rolling defect, always remember, rolling defect causes LAD type 2. Rolling defect causes LAD type 2. So it can be either selectin deficiency in the endothelium or Salil-Lewis X deficiency in the WBC. It can be anything. Now the point is, let us also know about the selectins, because it also comes in exam. There are three types of selectins: E-selectin, L-selectin, and P-selectin. E for endothelium. L is what? Leukocyte. But it's not exactly leukocyte. It's the lymphocyte thing of leukocyte. Okay. Lymphocyte. And P. P is for what? P is platelet. But this is also one previous year question, that platelet plus endothelium. The question will come platelet only, endothelium only, platelet plus endothelium. So be careful that P-selectin is present on both platelet and endothelium. Done. Next thing is that we should know what is the typical presentation of LAD2 deficiency. LAD2 deficiency will typically present with, you will see that the person will have short stature, he will always have infections, and he will have this Bombay blood group. What is Bombay blood group, by the way? Tell me. Bombay blood group. Remember that there is a small antigen called H antigen. There is this A, B, and when there is no antigen, then it is O. But sometimes there is this H antigen, there is RH, yes. But there is also a thing called H antigen. H antigen is present in everyone. That is why we do not do H typing. But this Bombay blood group people, they don't have even the H antigen. They have a very basic blood group where nothing is there. They do not have any antigens. Okay. Now one more thing. See, this is a very basic thing. But some people in the exam, they will always not write it as antigen or antibody. Sometimes instead of antigen, they will write agglutinogen, or instead of antibody, they will give agglutinin. So be careful. Like they can ask like a blood group is based on what? Blood group is based on what? Blood group is based on the antigens on the surface of RBC. That everyone knows. But remember that the other word for antigen is agglutinogen. Agglutinogen. Gen. Antigen, agglutinogen. And antibody is agglutinin. So, small things, remember. Okay, the next thing is LAD1. Then where is LAD1? LAD1 is the next step. That is adhesion. A for adhesion. Adhesion deficiency will cause LAD1. So adhesion is mediated by what? If here there is lectin, sialin, Lewis, here there will be something else. There is integrin on WBC. Remember, selectin is on endothelium, but integrin is on WBC. Then you have ICAM and VCAM. This is on what? On endothelium. Okay. Integrin on WBC, ICAM, VCAM on endothelium. That is adhesion. Deficiency leads to LAD1. And the typical presentation of LAD1 will be delayed separation of umbilical cord. What is the typical presentation? Delayed separation of umbilical cord. So this is the typical presentation. Then you have the last step is transmigration or diapedesis. So this is mediated by PECAM, PECAM. PECAM. And another question which can come is, this happens in which place? It happens in the venules, not capillaries. Most people will write this, they make this mistake. So remember, diapedesis happens in the venules. Okay, and PECAM, now you will ask me, ma'am, why there are two people everywhere, but here we have only PECAM? Because PECAM is present on both WBC and endothelium. So both the places we have PECAM. So done, the intravascular part is done. Okay, now let's go to the extravascular part. Okay, now coming to extravascular, COP, C is chemotaxis, opsonization, and P is phagocytosis. Now chemotaxis is mediated by what? Chemotaxis, there is this famous mnemonic called LIC, but personally I find it very useless. But anyway, the point is it is LTB4, this is interleukin 8, and this is C5A. If any of you know any mnemonics, then tell me. So LTB4, interleukin 8 and C5A, they mediate the chemotaxis. And you know steroids, how do they suppress inflammation? Steroids suppress inflammation by inhibiting chemotaxis. Okay, so remember steroids, which step steroids act in inflammation? Chemotaxis. Next thing is opsonization. So what are the things which mediate opsonization? IgG, C3b, fibrinogen and CRP. Okay, IgG, C3b, fibrinogen and CRP. And this IgG is FC part. I don't know if it's important. Never saw a question on it, but anyway. So this is the thing. The next step is phagocytosis. Phagocytosis can happen in the presence or absence of oxygen. Whether there is oxygen or there is no oxygen. Two things can be there. If there is no oxygen, those examples are major basic protein. MBP, major basic protein. They are present in the eosinophils. Lactoferrin. This you know, lacto, milk, so breast milk. Then you have defensins and cathelicidins. These are the examples of oxygen independent phagocytosis. Then you have oxygen dependent. There are two examples. One is MPO, myeloperoxidase. This is the most effective mechanism for phagocytosis. This is most effective phagocytosis, and they call it respiratory burst. Sometimes they, instead of MPO or something, they will write respiratory burst mechanism. So don't get confused. The next is NADPH oxidase. This comes in the question sometimes. The question is like chronic granulomatous disease, which enzyme is deficient? Or nitroblue tetrazolium test is done for which enzyme deficiency? So the point is, this is a previously frequently repeated question. The deficiency will lead to CGD, chronic granulomatous disease, and the test here is nitroblue tetrazolium. Nitroblue Zolium test. So the catch here is, if someone tells the test is positive, then usually when someone tells test is positive, it means the disease is there. That is what we mean. In the medical science, when in life, when someone tells positive, it means, wow, great, he's a normal person, he's a very positive person. But in medical science, if someone tells ki, arey tumhara positive aa gaya, then it's a cause of big headache. But see, this nitroblue tetrazolium, that is a special thing. If it comes out to be positive, it is actually normal. Positive means the blue color. Okay, and that is normal. Negative means this is whitish, it will be very pale, and this is CGD. So this can be a potential question. I'm not sure if AIMS has asked this, but NEET mein to abhi tak aaya nahi hai. But remember this, that nitroblue tetrazolium is a bit different. When it is positive, it is actually normal, and when it is negative, it is CGD. So that actually finishes everything in inflammation. But okay, another question which they are asking these few years was Chediak-Higashi syndrome. I don't know why they are asking it, but remember, just let us know about this Chediak-Higashi syndrome. So the defect is in the LYST gene, LYST gene defect, and this leads to a lysosome defect. Basically, it is a lysosome transporter. So that is what Chediak-Higashi syndrome is. And how are you supposed to diagnose it? The patient will come with albinism. Albinism, you know, right? White children. Albinism, no pigmentation. So albinism, and he might come with infections. Obviously, we are studying with this chapter, it is an infection thing. And they will come with some CNS problems, some kind of mental deficit or something, and they will come with bleeding. See. Albinism, infection, CNS, okay, these are very generic things, but albinism, bleeding, this thing should ring your ears. And infection, yes, of course, infection means it belongs to this immunodeficiency category of diseases. And the other features can be, you will have coarse granules in neutrophils, and sometimes they can frame the question like this, that in Chediak-Higashi syndrome, what is the pathology? So the correct option will be written like this, like the phagosome cannot fuse with the lysosome. So sometimes they write the option like this, that phagosome can't fuse with lysosome. The phagolysosome cannot be formed. So these are different ways of framing the question. So anyway, got it? Now I'll just give you a direct question. Just tell me that for a person with osteoporosis, what is the best or gold standard, what is the diagnostic modality, and how you are going to diagnose it? Okay, anyway, the point is that the investigation of choice or gold standard, that is the DEXA scan, okay, DEXA scan. And remember, in DEXA scan, you can either have a T score or you can have a Z score. Now, what is T score and what is Z score? So, T score is you are comparing that person's bone density to a young adult. You are comparing with a young adult. And Z score is you are comparing it with someone, with a standard person of the same age, a 60-year-old woman coming to you with bone pain, pathological fractures. Then you will compare her with the reference point is a normal 60-year-old woman. So same age, that is age matched, is Z score, and if you are comparing with young people, then it is T score. So always remember that in less than minus 2.5 you diagnose osteoporosis for T score, but for Z score it should be less than minus 2. Okay, why it is so? Because it's common sense, because young person will anyway have higher bone density. Isn't it unfair to compare a 60-year-old woman with a young person? So we are giving her a bit of relaxation ki koi baat nahi, up to 2.5, okay, it's okay. But in Z score, you are comparing her with a standard women of the same age. So there is no excuse that why she will have less bone density. There is no excuse. So we cannot forgive her. We will tell her no. We will only give you relaxation till 2. Till 2 it's okay, but beyond that, yes, we will call you an osteoporotic person. I'm not telling ki -2 up to that is normal. It's not normal. From -2 to -1, it is osteopenia. So, but anyway, the point is, for diagnosis of osteoporosis, the T score should be -2.5 and Z score should be less than -2. And sometimes they will directly ask you what is the gold standard or investigation of choice, that is DEXA. And T score is based on what? It is based on young people, and Z score is based on same age or age matched. They will write it like this in the MCQ. It is a age matched score. Okay. Some other questions, let me ask you, what is a typical scenario? What they will give in osteoporosis? Usually they will mention a postmenopausal female and she will come with a backache. This is the typical presentation of osteoporosis, postmenopausal female with backache. And when you do her X-ray, then what you will find? In her X-ray, you will find codfish vertebra. Of course, bone density is also less, so it will be more black than usual. It will look less white, that is what I mean. But also, this is a typical finding, codfish vertebra. And another important thing is biochemical parameters are normal. Her calcium, phosphate and alkaline phosphatase all are normal. This is a very important point. It comes in MCQ. Everyone see the codfish vertebra image from Google.